it, I was in and out of the room, um, but I adopted the diet. I haven't been to the meetings in a while, but just to say, I adopted the diet then, and I've stuck with it the whole way.
And that's been how long did you say?
3 years now.
Wow, congratulations. And how are you feeling? How things going overall from 3 years ago to today? Any changes?
Well, it's a little hard to assess.
This meeting is being recorded.
There's been so many life changes going on for me, moving, divorce, all kinds of stuff. So it's been a little hard to judge, but I certainly don't feel any worse.
Oh,
And
well, I guess that's a significant positive in this world of continuing aging.
yes, yeah, no, I feel good, and I'm active, very active. So I think, uh, and I don't miss meat, not at all.
Well, that makes two of us, at least, and a few more in the room, I suspect.
Anybody else new here, or is anybody new for the first time here? Tonight we're going to be talking about diabetes, part one. I'm going to go in depth on the types of diabetes and the cause of especially type 2 diabetes. So we'll be starting that soon, but I just want to make sure everybody has a chance to introduce themselves if they're new and how they found out about the classes. Anyone have anything they want to share before we get started?
I have a question.
Yeah, go ahead.
So I've been attending or watching the recordings of the Food Revolution docuseries, and I watched before coming on to this and cooking dinner. I watched the one for today, and they recommended a few things, and one of them was an algae-based DHA EPA supplement. I just was curious on yours and Charlie's response to that.
Yeah, so the science has kind of been pretty good. I was taking it for a while, and it's then there was a more recent study that came out that showed that the supplement doesn't actually cross the blood-brain barrier, so they couldn't detect elevated levels of DHA EPA in the brain when they studied it. So kind of the it's this question still out there, I guess, as far as whether it's a benefit or not, because it's if you look at sometimes those show studies where even of vegans, their DHA EPA levels aren't that high, but a lot of times the reason is because they're eating a lot of omega-6 fatty acids. So omega-6 fatty acids are the pro-inflammatory. They're in like the cooking oils and things like that, and so they'll be still eating a lot of maybe a too high of an amount of processed vegan food, so to speak, and so then they don't convert as much of the omega-3 from the short chain to the long chain. So the long chain omega-3, which is the best, we got the building blocks of omega-3, which is the ALA, which you get plenty of in things like chia seeds, flax seeds, walnuts, and some of those foods. And then we need to convert the shorter chain ALA into the longer chain DHA EPA. And omega-6 inhibits that. So most people, if they're keeping their omega-6 in check, not eating a lot of processed vegan food, they'll have plenty of the long chain DHA EPA. Now you can get it from also get it the long chain from things like sea vegetables like nori and wakame and some seaweed basically, and get plenty of the long chain DHA EPA. But as far as the supplements, they were mainly using them. They thought maybe they would be good for heart attack prevention, heart disease, and that didn't pan out. But then there's still some evidence that it's good for brain health to have more of the DHA EPA. But then again, in the supplement form, it didn't seem to cross that blood-brain barrier. But I don't know, do you have anything to add about that, Charlie?
Sure. So I actually listened to the talk on the revolution, food revolution, and one of the participants is who is it?
Joel Furman.
Joel Furman. Now, as it turns out, Joel Furman potentially has convinced the rest of the group that there may be some lower levels and older people, and that is kind of up for debate as to how it's measured. Unfortunately, he has a little conflict of interest, and that's he sells a DHA EPA supplement. So one must be kind of wary about, who you're listening to. And we've been listening to Greger, we've been listening to Clapper, we've been listening to, I don't know, Esselstyn. I don't think Esselstyn in his heart disease reversal, our number one killer, insisted that people take a supplement of DHA EPA. I haven't asked him directly, but I doubt that was part of his program. And I doubt that it was the program of Ornish 30 years ago for these people who had reversal of their heart disease and lived a long, long time without further episodes. So I, like Scott, also took some DHA EPA back starting 2 or 3 years ago, and started to take it for a while. And Clapper said, well, the evidence doesn't really hold up, and I'm not going to take it. I'm going to wait a year and see what happens. So he waited a year, and then he says, well, I don't know, there's still conflicting, and maybe to hedge the bets, I'll take some. And Greger kind of hedges it this way. He says, you may take it, you may not take it, maybe 2 times a week or 3 times a week. That's my take about what he says. He doesn't really have any strong emphasis one way or the other. So for my personal situation, my wife happened to have the DHA EPA testing done by mistake by one of her doctors. They ordered a test, and they did 1,001 tests on her. And her levels were just fine about 2 years ago, maybe 3. And I figure we've been eating this way it's 12 years now. At that time, it was 9 or 10. And I said, well, if her levels are fine by the way we're eating without doing supplementation, we're going to just keep doing that. But if you decide in your mind that that's something you think might be beneficial based upon who you're listening to for the moment, I don't have a problem with anybody trying to hedge their bets by taking that. But at the same time, I'm personally not convinced. And so I choose not to take it for my own personal health. But would I criticize anybody who chooses to take it? Absolutely not, because I really don't know. So that's a long answer for a murky subject. And, it's sort of, in my mind, a distraction from just doing healthy food choices, foods as they're grown in nature. My bottom
Right.
line.
I was surprised that they also sort of recommended creatine.
Yeah, so there's a new study that shows, and Greger actually is responsible, I think, for the enthusiasm for that. There has been a study that shows you may get some increased muscle mass, but only if you're doing significant amount of resistance exercise. Taking creatine by itself does nothing and he makes
Right,
it
right.
clear.
Right.
And they didn't make that clear when they were discussing taking creatine at their
They did
session.
not.
And
Right.
so that kind of troubles me that people are looking for a pill in our culture. And when you
Right.
tell them creatine's going to build muscle without telling them, you really need to do the resistance. And, you know, I think that's a big mistake.
It was, they kind of murked things up about calcium for me as well.
Yeah, they did address the issue saying, you know, calcium may be helpful for you. Make sure you get enough calcium, but if you get too much, it could be associated
Right,
with risk.
right.
So they did discuss that, but not to the
Right.
point where people could go away and say, should I be taking calcium supplements or shouldn't I? And the bottom line is Gregor's couple videos on our calcium supplements safe? Are they effective? That's what I would refer people to. Let them
Right.
make a decision. I've made the decision. I would get mine from the greens, the beans, and my
Right.
whole
That's
foods.
what I do. And I take D3. So I'm following your advice. I like
Okay,
not
I
taking
mean,
those. I don't like taking those horse pills. I'd rather eat.
okay, well, it's a good discussion because it's like on a lot of people's minds, and a lot of people are confused, you know, when they hear these different takes.
Yes, I agree.
All right.
Okay, thank
Well,
you.
You're welcome.
I'm gonna go ahead and get started here. Let me share my screen. I want to show you guys a couple of things on the website for tonight's class about diabetes first. So you can see my screen, I'm hoping. See my screen, Charlie?
Yep, I
Okay.
can see it.
All right, so I'm going to go to the resources first tab here. And I want to show you that, go to the books, links to books here so that you know one of the books that I recommend for tonight's class. So you can scroll down, we'll get down to the diabetes class. And you'll see right here, Mastering Diabetes by Cyrus Kambata and Robbie Barbaro. So it's a really good book if you're looking for a book talks all about diabetes and a lot of what I talk about tonight. I recommend that. And then I want to go back to the resources main page again and scroll down to handouts from classes. If you click on that, the first one there, and scroll down, I have a article I wrote about diabetes. So it kind of sums up a lot of what I talk about tonight. So if you kind of want to have your own printed version or just look at it here, I'll click on it. It's just an article I wrote. It's pretty long, but kind of sums up what essentially what I'm going to talk about tonight. And of course, this class is being recorded. So if you want to watch it again, because I go too fast or there's something you didn't quite understand, you can do that. Let me go out here. So that's what I wanted to show on the website. And let me close this. Get to my PowerPoint here. All right, diabetes. Let's talk about that. There comes a point where we need to stop just pulling people out of the river. We need to go upstream and find out why they're falling in. So I'm going to talk about the different types of diabetes, but I want to kind of give you a little background into my history with diabetes, with my education on it, and kind of how I got to be, you know, a little bit of a addition to my overall story of how I got into nutrition and lifestyle medicine. I wanted to give you a little bit of background on diabetes because I think it will help to figure out how I kind of came to a different conclusion with diabetes and, you know, how I got there. So back in 2005 is when I graduated from PA school at OHSU, and the first job I actually had was at a community health center, which ends up where I'm working now, but started at a community health center in Salem. And at that clinic, there was a lot of it was really tight budget. We didn't have a lot of money to work with, and so a lot of the providers there, we all kind of had our own areas of expertise. And so we would still refer patients to specialists that needed to, you know, like endocrinology for someone with diabetes, rheumatology, cardiology, all the different specialties. But what we try to do first off, if we could manage it, is refer within our own clinic to people that had extra knowledge or expertise in a certain area. So, someone might be really good with women's health, or another person with autoimmune diseases, another person with diabetes. And I kind of became one of the ones that was the go-to for diabetes, because I just have always had a really big interest in diabetes and did a lot of extra study and education, went to conferences, was really into it. So I was really in that whole mold at that time, back in, this is 2005 to 2009, basically in that time frame. And then at that time there was a kind of the thought process was to really treat patients with diabetes really aggressively, try to get their blood sugars down to as close to normal as you could. However you could do that with, with medications, with insulin, try to get people on insulin sooner if they needed it, and just really try to drive down the blood sugar to normal. And the thought was, well, maybe if we got people's blood sugars essentially normal, like someone without diabetes, maybe they wouldn't have the heart attacks and the strokes and the blindness and the kidney failure and the amputations and the neuropathies and all the things that, and the retinopathies and all the things that go with diabetes. And so that was kind of the mindset. And then in 2008, I went to the American Academy, or it was actually the ADA, the American Diabetes Association. I went to the national conference. It was down in San Francisco. And when I went there, it was really exciting, because that whole philosophy was the kind of the gold standard. But what was exciting was that in 2008, there was going to be 4 different studies that were going to be published. And it was the Accord study, the Advanced study, and the VA 2 different ones through the VA studies. And so the studies that were going to show the outcome of the really aggressive management of diabetes, how did the patients fare? And so we were all really excited at the conference to get the results. And we found out, it was disappointing, we found out that they had to stop 2 of the studies early, because the patients that were in the really aggressively treated group were actually dying sooner, actually caused more deaths. And so they had to stop the studies early. And so that was really disappointing. And at the time, we were like, okay, well, now what? Kind of back to the drawing board. So even though that was 2008, and I didn't find out about nutrition and whole food, plant-based nutrition and lifestyle medicine until 2012, it kind of changed my mindset, at least as far as, wow, that didn't work out so well. I mean, there was some of those studies did show slight decrease in the some of the kidney damage and some of the like retinopathy in the eye. A couple of the what we call microvascular changes did improve a little bit, but the macrovascular, the big, the heart attack, the stroke, those kinds of things, the patients were dying from those things that were aggressively treated. So I just wanted to give you that little background before I started talking about diabetes. So let's start with type 2 diabetes. That's 90 to 95% of all the diabetes. So when you hear about people saying, oh, I have diabetes, we developed it, whether it was in their teen years or 20s or any age above that, it's likely the type 2 diabetes. Now there are kids as young as 8 and 9 years old that are developing type 2 diabetes as well, which is really, really a sad thing. But so most of diabetes that I'll be talking about tonight is the type 2 diabetes, which is caused by insulin resistance, which I'll talk to you guys about in here just a little bit. And then, so by definition, it's an A1C of 6.5% or greater. If you guys know what an A1C is, which I can talk a little bit more about, and or a fasting blood sugar greater than 125, and a random blood sugar greater than 200. Those are the kind of the criteria for a diagnosis of type 2 diabetes. And then pre-diabetes is a A1C of between 5.7 and 6.4%. So A1C is basically we have there's sugar molecules that stick to different kinds of proteins, and our hemoglobin is a type of a protein that carries our oxygen. And so a certain amount of sugar will stick to it. It's glycolated is what we call it. So glyco meaning sugar. So the hemoglobin molecule gets glycolated, and get some sugar attached to it. And normal is 5.6% of our hemoglobin or less have sugar attached to them. And so that would be normal, 5.6 and below. And each percent number corresponds to an overall blood sugar. So say 140 is like your average blood sugar over a 24-hour period for up to 3 months, and that would give you that A1C number. So it corresponds to a specific number, and you can look it up online on Amazon, and and it'll give you a chart that what's the percent A1C, what does that equate to a overall blood sugar. So if you were to wear a 24-hour glucose monitor for 3 months, you could figure that out, what your A1C is based on your average blood sugar. And the reason it's 3 months is because we make new red blood cells about every 3 months, between 3 and 4 months. And so basically every hemoglobin molecule you have in your body right now wasn't there 4 months ago. And so then as a new batch comes through, then you'll get a new number. That's why your doctor will often, if with diabetes, check your A1C every 3 months or every 6 months, depending on how high it is. And it gives you a fresh number, a reflection of what the blood sugars have been over the past 3 months. Does anybody have any questions about A1C? Does that make sense? You probably see it in the commercials. Lower my A1C, right? So that's what that is. And then let's go into what type 1 diabetes is. So type 1 diabetes, we used to call it juvenile onset because it happens mostly in children. And that's still true, but we tend to not call it that anymore because, as I mentioned earlier, kids get type 2 diabetes as well. So type 1 diabetes, what's different about that is that your own immune system attacks the cells that make insulin in your pancreas. And so they get destroyed, and so you don't make any more insulin. And so no insulin, then your blood sugars go up really quickly. It's usually diagnosed, again, most often in children and teens are most common ages. And so you'll basically just all of a sudden you're thirsty all the time, you're urinating frequently, you're losing weight and feeling fatigued, and you'll check your blood sugar, and usually it's 300 or 400, really high, because that's usually how high it gets to have a lot of those symptoms. And then you get diagnosed that way, and you can check for antibodies in the bloodstream against insulin producing cells, and you'll get a diagnosis that way. But that's only about 5% of all diabetes out there is the type 1. And type 1 is not caused by insulin resistance, it's an autoimmune. But the irony is, or the caveat is that you can develop insulin resistance also as a patient with type 1 diabetes. And so then it's essentially like you have type 1 and type 2 diabetes. And we're figuring out that insulin resistance may be responsible for a lot of the complications with all types of diabetes. So we'll talk about insulin resistance here in a little bit. I just kind of wanted to give you the main difference then is type 1, you don't make insulin, so you're always going to have to inject insulin. So no matter what you do with your diet and lifestyle, you're always going to be on insulin. It's not reversible. And so, but you can still treat the insulin resistance and still lower your risk of complications with a healthy diet and lifestyle, which we'll talk about. So type 2 and type 1, hope you guys got the difference there. And then I won't spend too much time on these other two because they're a little bit more, either more self-explanatory or a little bit too complicated. So type 1.5 diabetes, another name for it is LADA, which stands for latent autoimmune diabetes in adults. And what that is basically someone that has type 2 initially, and then over time, for unknown reasons, some genetic factors and autoimmune factors, you then get positive antibodies that destroy the insulin producing cells, just like type 1, but it happens in someone that's usually an adult, a little bit older. They've probably had type 2 diabetes for a certain amount of time, and then they suddenly don't make any more insulin. And then you can check blood work, you can check a fasting C-peptide and some of these diabetes anti-insulin antibodies. And if those are positive, there's some criteria, and you could say type 1.5 diabetes. So you essentially treat someone with type 1.5, same as with type 1, they're going to need insulin. but again, can also have insulin resistance, and so we can improve the situation with by reversing or lowering insulin resistance. And then gestational diabetes, a lot of you probably already know that's the diabetes when you're pregnant. So you'll do all women that have had babies know they get a glucose tolerance test, and if they fail that, and they can show signs of, so it's insulin resistance, and essentially they have type 2 diabetes while they're pregnant. Most of the time when they deliver the baby, the diabetes goes away, and so then they don't have diabetes anymore. But we do know from studies that women that have had gestational diabetes are at increased risk of developing type 2 diabetes later on, and they likely have lots of insulin resistance hanging out there. So that's one that's also very, very beneficial to diet and lifestyle. So anyone, before I move on, anyone have any questions about these types? It's, there's no test, so you don't have to remember these. I just kind of wanted to give you some basic background. Anything in the chat, Charlie?
I don't see any chat comments so far. Let's see if anybody's raised their hand. I'm gonna expand the view out here. See about if the gallery. Don't be shy. Anybody have a question? A thought? A comment? And I don't see any, Scott.
Okay. Well, let's go over just some
Oh,
statistics.
wait, here's
go
a
ahead.
hand up. Trouty. Go ahead and unmute.
How is the percentage of gestational diabetes?
I'm not sure the exact prevalence of it. It is pretty common. I don't know the exact prevalence. Would have to look that up. But
Okay,
it is quite common. Yeah, good question. And so I have to update these every year, and these have been, for the last several years, I've been updating this presentation, and the numbers keep going up every time I look them up on the CDC website. So as of 2023, 38.4 million in the United States diagnosed with diabetes, 97.6 million with pre-diabetes, and out of those, only 1 in 10 even know they have the pre-diabetes. So that's 136 million Americans that have either diabetes or pre-diabetes, which is about a third of the population. So that's pretty astounding when I saw that. And then the total direct and indirect costs of diabetes in the United States in 2022 was $413 billion. It's a very costly disease. So I'm going to show a quick video on diabetes from Dr. Greger, just some prevalence, and then we'll move on.
Before you do that, it's 3 to 8% of all pregnant women are diagnosed with gestational diabetes, 200,000 for the year.
3.8%?
3 to 8%.
Oh, 3 to 8%. Okay. Over 200,000. Wow, that's a lot.
Yeah.
Thanks for looking that up.
Okay.
In just 1 decade, the number of people with diabetes has more than doubled. According to the Centers for Disease Control and Prevention, by 2050, 1 out of every 3 of us may have diabetes. What's the big deal? Well, the consequences of diabetes are legion. The #1 cause of adult onset blindness, the #1 cause of kidney failure, the #1 cause of surgical amputations. What can we do to prevent it? Well, the onset of type 2 diabetes is gradual, with most individuals progressing through a state of prediabetes, a condition now striking approximately 1 in 3 Americans. But only about 1 in 10 even knows it. Since current methods of treating diabetes remain inadequate, prevention is preferable, but what works better, lifestyle changes or drugs? We didn't know until this landmark study was published in the New England Journal of Medicine. Thousands were randomized to get a good double dose of the leading anti-diabetes drug, or diet and exercise. The drug, metformin, is probably the safest diabetes drug there is. Does cause diarrhea, and about half of those who take it, makes 1 in 4 nauseous. About 1 in 10 suffer from asthenia, from the Greek meaning lack of strength, causing physical weakness and fatigue. but the risk of being killed by the drug is only about 1 in 66,000 every year. And the drug worked. Compared to placebo, in terms of the percentage of people developing diabetes within the 4-year study period, fewer people in the drug group developed diabetes. But diet and exercise alone worked better. The lifestyle intervention reduced diabetes incidence by 58%, compared to only 31% with the drug. The lifestyle intervention was significantly more effective than the drug and had fewer side effects. More than 3/4 of those on the drug reported gastrointestinal symptoms, though there was more muscle soreness reported in the lifestyle group on account they were actually exercising. Other studies subsequently found the same result: non-drug approaches superior to drug-based approaches for diabetes prevention. And the 50% or so drop in risk was not for people that actually improved their diet and lifestyle, but just those instructed to improve their diet and lifestyle, whether or not they actually did it. Check this out. This is one of the most famous diabetes prevention studies. 500 people with prediabetes randomized into a lifestyle intervention or control group. And during the trial, the risk of diabetes was reduced by that same 50 to 60%. But only a fraction of the patients met the modest goals. Right? Even in the lifestyle intervention group, only about a quarter were able to eat enough fiber, meaning whole plant foods, and cut down on enough saturated fat, which in this country is mostly dairy, dessert, chicken, and pork. But they did better than the control group, and fewer of them developed diabetes because of it. But what if you looked just at the folks that actually made the lifestyle changes, met at least 4 out of 5 of those wimpy goals? They had 0 diabetes. None of them got diabetes, 100% drop in risk. Bottom line, type 2 diabetes can be prevented by changes in lifestyle, even in high-risk pre-diabetic subjects. The fact, then, that type 2 diabetes, a largely preventable disorder, has reached such epidemic proportion is a public health humiliation.
And I was one of those people too, so if those of you know my story already, in 2012, I had a A1C of 6.2%, which is in the pre-diabetes range. And then a little bit over a year later, it was down to 4.7. I think I did it my A1C again last summer, and it was 4.5. So completely normal. Anything below 5.6 is normal. So yeah, I reversed my pre-diabetes. So any questions about that video?
You know the name of that video, in case someone wanted to look it up?
It's just, I'm not sure. I mean, this says, you can see it on, if you do diabetes on the search, go to the nutritionfacts.org and click on the diabetes. There's a whole ton of videos on diabetes, and you can see these little pictures, and you can see this particular one.
Very good.
So yeah.
Okay.
I have a question.
Yeah, go ahead.
My dad's 86 with type 2 diabetes, and I believe his A1C could be slightly higher than what would be considered normal, because I was told that due to his age, they don't want it actually to be too low. Have you heard about that?
Yeah, exactly. So that goes back to those studies I was talking to you about back in 2008. Those 2 trials, they had to stop sooner because of the complications that it was causing, heart attacks and strokes, because we were trying to drive people's A1Cs too low. So I've heard, I don't know if it's a gold standard, but I know I've heard a lot of other medical providers say you basically take the patient's decade, and that's your A1C target. So normally you would say we try to get people down around 7%. We're usually pretty happy if they're at 7, upper 6s or low 7s. If it's over 8%, we're usually not happy. But then if somebody's in their 80s, we usually are happy with 8%. So, and then if they're 90, we would be happy with 9%, because the reason is because the more you drive the blood sugar down, the A1C down, the higher your risk of hypoglycemia, getting too low. And we know that when you get too low, it causes a lot of stress on the body. It's actually worse to be too low than even to be too high. And so if you drive it too low, it causes a lot of stress on the body. And if somebody has, lots of risks for heart attack and stroke, which everyone with diabetes is at high risk for heart attack and stroke, then you potentially could incite a heart attack or a stroke by having them get too low on their blood sugar. So that's exactly right with what you said there.
Thank you.
Yeah.
I have a question about, is there a myth that I was talking to somebody about diabetes and they said, no, the fat helps your body not absorb the sugar or something. And so it was good for people with diabetes. Is that
Great question. Let's get into it right now. I'm gonna talk about what insulin resistance is. All right. And so what insulin resistance is fat being stored in tissues that are not designed to store fat. So that's the cause, caused by storage of fat in tissues that are not designed to store fat. So we're designed to store fat in our subcutaneous tissue, in our stomach and our hips and our thighs and all over our body. And that's kind of what we say is, Dr. McDougall says that's the metabolic dollar. Fat is to be stored for energy to be used later if we don't eat, and then we have fat storage. But there's some genetic reasons that people tend to store fat in these other tissues. And the other tissues I'm talking about are inside your muscles, inside your liver, and inside your pancreas primarily. So if you're storing fat in your muscles and in your liver and in your pancreas, that's not normal. Those tissues are not designed to store fat. There is a certain amount of fat that comes in all the time because let's just stick with the muscle cell. The muscle cell can burn sugar and it can burn fat. And so there's a little bit of fat coming into the muscle cell because we have fat in our diet no matter what we eat. Even a 100% whole food plant-based diet is still about 10% fat. So you're getting fat from every food you eat. And so your muscle cell can burn the sugar, can burn the fat, and that's what it's designed for. But if there's excess fat stored in your muscle cell, and of course in the liver and the pancreas, like we talked about, that's not normal. And so what happens with insulin resistance is there's so much fat in there that your muscle cell says when the insulin's trying to unlock the door so the sugar can come inside from the bloodstream into the muscle cell to get used for energy, the muscle cell says, no, you can't come in, sugar, because we have so much fat in here. We need to burn that up for energy first before we'll let the insulin open the door and let the sugar come in. That's exactly what insulin resistance is. So the insulin doesn't work. Insulin's the key to unlock the door so the sugar can come inside, but it can't do it because there's so much fat in there. So what is, and I'm gonna show some videos and you're gonna see a cartoon of this whole thing so you can better understand it, is that it's actually the fat in our diet that causes insulin resistance. And so the goal is to get rid of insulin resistance and increase insulin sensitivity so that you can eat all these whole plant foods and you can be tolerant to sugar in your bloodstream. It'll come in through, because all the food we eat raises our blood sugar, and then that sugar can easily get out of the bloodstream and into the muscle cell where it is used for energy. But that's what high insulin sensitivity is. And towards the end of today's presentation, I'll talk to you about what low carb keto diets do, because some of you might be confused because they'll say, like the other person was commenting, that eating all that fat will make the blood sugar go down, and it does, but at a cost. And I'll talk to you guys about that in a little bit. But first, why is insulin resistance so bad? Is because all of these chronic conditions are influenced by insulin resistance. And so we used to think that, even going back to 2008, those studies I was telling you about, we thought that the high blood sugar was causing a lot of these problems on this list here. And don't get me wrong, really high blood sugars, over 200, 300, those aren't good, and those cause inflammation in the body, and influence some of these things too, but not as much as the insulin resistance. And the reason we know this is because of some of those studies that in 2008. So even though we got people's blood sugars down close to normal, so they didn't have high blood sugar, because we were so aggressive with their insulin and their medications, we gave them essentially normal blood sugars. They were still having a lot of these complications, and they were dying sooner. So we actually are now realizing that the insulin resistance might be contributing to most of the problems with all of these things: heart disease and cancer, and the kidney disease and Alzheimer's. Alzheimer's disease is often referred to as insulin resistance of the brain, or even there's some that even say type 3 diabetes, because one of the big aspects of Alzheimer's disease is glucose dysregulation. What that means is the way that the metabolism and the blood sugars are being processed or is abnormal, and that's one of the aspects of Alzheimer's disease. Is there's like 3 different things that really contribute to Alzheimer's disease, and the glucose dysregulation is one of the key things. And then there's fatty liver, because remember I said insulin resistance is storing fat in places that are not designed to store fat. One of them is including the liver, and that's now beating out alcohol as the main cause of liver cirrhosis now, is fatty liver disease. You might have heard it as NASH, non-alcoholic steatohepatitis. And then of course, high cholesterol is leading to heart disease and strokes and high blood pressure, and obesity, PCOS, neuropathies, retinopathies, erectile dysfunction. So we know insulin resistance is influencing all of these things, and then some. And so it's really important that we understand insulin resistance and try to reverse it. So we'll talk more about how to do that. So here's another. I'm going to show a couple more videos to kind of help you better visualize what insulin resistance is, and hopefully it'll make sense. And then I can answer any questions about insulin resistance after these couple of videos here.
Both prediabetes and type 2 diabetes is caused by insulin resistance, which is now accepted to be closely associated with the accumulation of fat within our muscle cells. This fat toxicity inside our muscles is a major factor in the cause of insulin resistance in type 2 diabetes, as it interferes with the action of insulin. I've explored how fat makes our muscles insulin resistant, how that fat can come from the fat we eat or the fat we wear, and how all fats are not the same. It's the type of fat found predominantly in animal fats relative to plant fats that appears to be especially deleterious with respect to fat-induced insulin insensitivity. But this insulin resistance in our muscles starts years before diabetes is diagnosed. This is a graph of fasting blood sugars in the 13 years prior to the onset of diabetes. Insulin resistance starts over a decade before diabetes is actually diagnosed, as blood sugar levels slowly start creeping up. And then, all of a sudden, the pancreas conks out and blood sugars skyrocket. What could underlie this relatively rapid failure of insulin secretion? At first, the pancreas pumps out more and more insulin, trying to overcome the fat-induced insulin resistance in our muscles, and high insulin levels can lead to the accumulation of fat in our liver, called fatty liver disease. Before diagnosis of type 2 diabetes, there's a long, silent scream from the liver. As fat builds up in our liver, it becomes resistant to insulin too. Normally, the liver is constantly producing blood sugar to keep our brain alive between meals. As soon as we eat breakfast, though, the insulin released to deal with the meal normally turns off liver glucose production, which makes sense, since we don't need it anymore. But filled with fat, the liver becomes insulin resistant like our muscles, and so doesn't respond to the breakfast signal, and so keeps pumping out blood sugar all day long on top of whatever we eat. So the pancreas pumps out even more insulin to deal with the high sugars, and our liver gets fatter and fatter. That's one of the 2 twin vicious cycles of diabetes. Fatty muscles, in the context of too many calories, leads to a fatty liver, which leads to an even fattier liver. This is all still before we have diabetes, but then the next vicious cycle starts. A fatty liver can be deadly, so the liver starts trying to offload the fat by dumping it back into the bloodstream in the form of something called VLDL, and that starts building up in the cells of the pancreas that produce insulin in the first place. So now we know how diabetes develops. Fatty muscles leads to a fatty liver, which leads to a fatty pancreas. It is now clear that type 2 diabetes is a condition of excess fat inside our organs. The only thing that was keeping us from diabetes, from unchecked skyrocketing blood sugars, is that pancreas was working overtime, pumping out extra insulin to overcome insulin resistance. But as the so-called islet or beta cells in the pancreas are killed off by the fat buildup, insulin production starts to fail, and we're left with the worst of both worlds, insulin resistance combined with a failing pancreas. Unable to then overcome the resistance, blood sugar levels go up, and we have type 2 diabetes. This has implications for cancer as well. Obesity leads to insulin resistance, and our blood sugars start to go up, so our pancreas starts pumping out more insulin to try to force more sugar into our muscles, and eventually the fat spills over into the pancreas as well, killing off the insulin-producing cells, and we've got diabetes, in which case we may have to start injecting insulin at high levels to overcome the insulin resistance, and these high insulin levels promote cancer. That's one of the reasons we think obese women get more breast cancer. It all traces back to fat getting into our muscle cells, starting insulin resistance, fat from our stomach, or fat going into our stomach. So now it should make sense why the American Diabetes Association also recommends reduced intake of dietary fat as a strategy for reducing the risk of developing diabetes.
I'm going to show you that cartoon that demonstrates insulin resistance. I used to do well, I did it at the YMCA on Sunday, kind of a visual experiment of how insulin resistance works, but since we can't do that, this cartoon will kind of demonstrate it for you.
Studies dating back nearly a century noted a striking finding. If you take young, healthy people and split them up into two groups, half on a fat-rich diet and the other half on a carb-rich diet, within just 2 days, this is what happens. The glucose intolerance skyrockets in the fatty diet group. In response to the same sugar-water challenge, the group that had been shoveling in fat ended up with twice the blood sugar. As the amount of fat in the diet goes up, so does one's blood sugar spikes. It would take scientists nearly 7 decades to unravel this mystery, but it would end up holding the key to our current understanding of the cause of type 2 diabetes. When athletes carb load before a race, they're trying to build up the fuel supply within their muscles. They break down the starch into glucose in our digestive tract. It circulates as blood glucose, blood sugar, and is taken up by our muscles to be stored and burned for energy. Blood sugar, though, is like a vampire. It needs an invitation to come into our cells, and that invitation is insulin. Here's a muscle cell. Here's some blood sugar outside, waiting patiently to come in. Insulin is the key that unlocks the door to let sugar in our blood enter the muscle cell. When insulin attaches to the insulin receptor, it activates an enzyme, which activates another enzyme, which activates 2 more enzymes, which finally activates glucose transport, which acts as a gateway for glucose to enter the cell. So insulin is the key that unlocks the door into our muscle cells. What if there was no insulin, though? Well, blood sugar would be stuck out in the bloodstream, banging on the door to our muscles, and not be able to get inside, and so with nowhere to go, sugar levels would rise and rise. That's what happens in type 1 diabetes. The cells in the pancreas that make insulin get destroyed, and without insulin, sugar in the blood can't get out of the blood into the muscles, and blood sugar rises. But there's a second way we could end up with high blood sugar. What if there's enough insulin, but the insulin doesn't work? The key is there, but something's gummed up the lock. This is called insulin resistance. Our muscle cells become resistant to the effect of insulin. What's gumming up the door locks in our muscle cells, preventing insulin from letting sugar in? fat, what's called intramyocellular lipid, fat inside our muscle cells. Fat in the bloodstream can build up inside the muscle cell, creating toxic fatty breakdown products and free radicals that can block the signaling pathway process. So no matter how much insulin we have out in our blood, it's not able to open the glucose gates, and blood sugar levels build up in the blood. This mechanism by which fat, specifically saturated fat, induces insulin resistance wasn't known until fancy MRI techniques were developed to see what was happening inside people's muscles as fat was infused into their bloodstream. And that's how they found out that elevation of fat levels in the blood causes insulin resistance by inhibition of glucose transport into the muscles. And this can happen within just 3 hours. One hit of fat can start causing insulin resistance, inhibiting glucose uptake after just 160 minutes. Same thing happens in adolescents. You infuse fat into their bloodstream, it builds up in their muscles and decreases their insulin sensitivity, showing that increased fat in the blood can be an important contributor of insulin resistance. And then you can do the opposite experiment, lower the fat in people's blood, and the insulin resistance comes right down. Clear the fat out of the blood, and you can clear the sugar out of the blood. So that explains this finding. On a high-fat diet, the ketogenic diet, insulin doesn't work as well. Our bodies are insulin resistant. But as the amount of fat in our diet gets lower and lower, insulin works better and better. This is a clear demonstration that the sugar tolerance of even healthy individuals can be impaired by administering a low-carb, high-fat diet. But we can decrease insulin resistance, the cause of prediabetes, the cause of type 2 diabetes, by decreasing saturated fat intake.
Okay, so that last, let me stop sharing for a second. So that last video, that last study he showed there that was a glucose tolerance test. So the low-carb ketogenic diet, which I'm going to talk more about in a minute on the next slide, it makes the glucose tolerance test really perform poorly. So your sugar really rises a lot when you've eating that type of a diet. So you give a sugar challenge and you have tons of insulin resistance and really poor insulin sensitivity. But one other comment I wanted to make about the MR spectroscope that he talked about in that last video, looking to where the fat is. The first group of people that they really studied that on was the Asian population, because in Japan and China and Asian countries, they were developing type 2 diabetes they are still at really high rates, and oftentimes they're not even overweight. So we're like, because in America, it was kind of the typical person that gets type 2 diabetes is somebody that's 20, 30, 40, 50 pounds overweight. And so then we thought, okay, so yeah, you have obesity, then you develop type 2 diabetes. But then we knew there was genetic factors too, because not everyone that's overweight develops diabetes. So we knew there had to be more to it than that. But then when we started seeing the Asian populations going from rice and vegetables to suddenly eating, Kentucky Fried Chicken and Pizza Hut, we're like, they weren't even really showing any obesity yet. I mean, starting to, but before they were even getting obese, they were already developing type 2 diabetes. And so we're like, well, what's going on here? And so we started doing these MRI spectra scans on them, and what you can see with those studies or those images is where the fat is distributed. Where is their fat? And we found it in their muscle cells. We found it in their liver. We found it in their pancreas, just like Dr. Greger said in those videos. And so they're very genetically predisposed to developing diabetes. So that's kind of where we got the science now on the intramyocellular lipid and all of that. So any questions about insulin resistance and any of that before I talk more about low carb keto diets?
There is Joan and then Leslie.
Okay, so if your muscles have this fat in them and you're obese, what happens when you try to do resistance or weight training? Are you putting additional threatening stress on your body?
Well, so once you get, if you switch your, are you talking about if you switch your diet, or you just talk about
Not
exercise?
switching a diet. No, so you've developed a body that's in crisis because it has this extra fat in the muscles. And now you say, well, I'm going to go and do a bunch of really hard resistance training. So what's the result going to be?
You can still build muscle. Your muscle cells still work just fine. They just don't, they're not taking the sugar's not coming in as easily as it would. So you could still build muscle and be very strong, but still have lots of insulin resistance. So it'll be hard to be. I mean, you might not have much subcutaneous fat. You might be pretty lean, but you have fat in your muscles and your fat in your liver and pancreas, and so you could still be riddled with insulin resistance, but you could still exercise and build muscle and function pretty normally and not even really know you have it.
But would that trigger like extra heart issues or some, I mean,
we know,
because
yeah.
of the stress.
Sure, and if somebody has insulin resistance, we know they're at higher risk for heart attacks and strokes and all those things on that list I showed earlier. And so you by putting that stress on your body, you could drop, essentially drop dead in the gym from a heart attack, and that happens all the time. Especially people that are doing low carb keto diets, they have terrible insulin resistance. But I'll talk to you guys in a minute about how their blood sugars can be normal. Even their insulin levels can often be fairly normal. That's for a different reason, but they're still at really high risk for heart attack and stroke. And that's what the 5-year studies that have been done on people following low carb diets show is about a 51% increased risk of a heart attack after a 5-year study.
Okay, thanks.
Welcome.
Leslie and then Trouty.
Hi, yeah, I think I basically understand. I just wanted to confirm, are we basically talking about saturated fat or all dietary fat? It sounds like it's primarily focused on saturated fat, but if you could expand on that a little bit.
Sure. So yeah, saturated fat's the biggest culprit. It causes the most free radicals and toxic metabolites like ceramide can accumulate in that muscle cell and block the insulin signaling pathway even more severely. But essentially all fat does it too. So if you're putting olive oil on your food, if you're eating maybe too many avocados, nuts and seeds, even those are healthy foods, though that plant fat can also accumulate in the muscle cells. So you want to, if somebody is trying to reverse diabetes or insulin resistance, they want to really be careful with those plant fats as well. But I guess the difference is, even though the plant fats are the healthier fats and they can lead to insulin resistance too, they don't tend to be the fats that clog up your coronary arteries. So you're still better off eating the plant fats than the animal fats. But if you're trying to reverse insulin resistance and reverse type 2 diabetes, for example, you want to really be careful with the plant fats as well.
Trouty.
Unmute, Trouty.
I was wondering, how long will it take when you stay strictly on a plant-based diet and leave off the avocados and all that? How long does it take to get back to normal from a pre-diabetes or diabetes?
It's a great question. It can vary a lot. I've had patients that went from an A1C of 14% to 5.5% in 6 months, and were on so I've had patients that were on insulin, on a bunch of diabetes medications, and had an A1C of 14%, and 6 months later, off all medications, off all insulin, and down at 5.5% in 6 months. Then I've had people that it's taken a year or longer, and because there's a lot of factors. Everyone's level of insulin resistance is different. Everyone's diet's a little different. And then the other thing too is when people have a lot of stored subcutaneous fat as well, is the fat inside the muscles and the liver and the pancreas. As you're losing body fat, some of that fat spills into the bloodstream and can get stuck inside the muscle cells too. So a lot of times when people are losing weight, it can slow things down as far as reversing the insulin resistance. So it is important to not only get rid of the fat in the muscles and the liver and the pancreas first, which is usually what happens. But as you're losing the subcutaneous fat too, sometimes that can slow down the process of reversing the insulin resistance, because it again can get stuck in there too. But of course you're getting healthier all the while, so you're reducing your risk of heart attack and stroke and all those other things at the same time. So you just got to keep at it. So it can vary from a few weeks to months to years sometimes. It just depends on the person.
Mhm. Thank you.
Welcome.
There was a question in the chat room about person who is 60 years old. She doesn't think she's ever been screened for diabetes. But the reality is you probably have been screened with just a chemistry panel, because it has a glucose level. And if you do a fasting level, if the value's under 100, your doctor is probably thinking, oh, well, that's probably okay. But if it's up around close to the 100 or above the 90s into the 110, then they might consider doing a hemoglobin A1C, which is a measure of how your sugars have been running over the last 3 months. So if you've had normal blood glucose tests, you shouldn't worry about the issue of being diabetic too much, especially if you're eating healthy. If you're eating unhealthy, you should worry about it even if your blood sugar's normal. My thought.
Yep. Well, let me show the keto caveat, and I think the rest of the time we'll have for questions. I don't know if can I share I can't share my screen. David, Guido, yeah, there you go.
There you go.
Somebody had shared their screen on accident. So okay, so let me go back here. Get escape. Here we go. Play from current slide. Okay, so the keto caveat, let's talk about that. I think that's I want to talk about, some other stuff. So keeping carbohydrates low. So when you know about people that follow ketogenic low carb diets, they keep their carbohydrates really low, usually 20, 30, 40 grams a day of carbohydrate. And so when you do that, your level of carbohydrates and thus level of sugar in the bloodstream gets really low and stabilizes. So it can go down even close to normal, even people with diabetes. And so they're just not taking in the sugar or with the carbohydrates, because they're cutting out all the beans and grains and fruit, and they're mostly eating protein and fat from lots of animal products, maybe some vegetables. But because their carbohydrate content's so low, their sugar is really low. And so things like their A1C will get better, their fasting insulin levels will get better, because if you're not eating very much carbohydrate or sugar, your blood sugar is going to be lower. And if you don't have as much of the sugar in the bloodstream, then you don't need as much insulin. So your insulin requirements go down, fasting blood sugar goes down. And so that will look good. So your serial markers, your numbers will actually look good. And then if you're losing weight, a lot of times your cholesterol will drop, because no matter how you lose weight, your cholesterol will drop. I mean, if you went on chemotherapy, your cholesterol would drop. If you picked up a cocaine habit and lost a bunch of weight, your cholesterol would drop. So would your sugar and insulin levels and all that, the same stuff. So it doesn't mean you're actually healthier because those numbers get better. And so as far as whether these numbers, A1C, fasting insulin requirement, fasting blood sugar, that will not tell you whether or not you have insulin resistance or not. It contributes information, but that's incomplete information about the presence of insulin resistance. You actually need to do a glucose tolerance test or a carbohydrate to insulin ratio, which people that are on insulin, either for type 1 or type 2 diabetes, understand what a carbohydrate to insulin ratio is. It's basically people, when they inject insulin, especially mealtime insulin, they'll have a formula. They'll know how many grams of carbohydrates they're going to eat in a meal, and then they figure out how many units of insulin they need to give. So some people are like 5-to-1, 4-to-1 ratio. So say you're a 5-to-1 ratio, you need a unit of insulin for every 5 grams of carbohydrate you're going to eat. So if you're going to eat 20 grams of carbohydrate in your meal, you're going to need 4 units of insulin. And so you'll have these carbohydrates to insulin ratios. So having a low ratio is actually a sign of having a lot of insulin resistance. So somebody that can eat 20 grams of carbohydrate for every 1 unit of insulin they need, that's really low insulin resistance, basically little to no insulin resistance and really high insulin sensitivity, because with just 1 unit of insulin, they can metabolize 20 grams of carbohydrate. And so that glucose tolerance test, where you give a glucose challenge like they do for pregnant women to detect gestational diabetes, you will see what's the blood sugar spike do when you ingest a certain amount of sugar, a certain amount of glucose, and that will actually tell you whether or not you have insulin resistance. So those two tests, glucose tolerance test and carbohydrate to insulin ratio, are more complete markers of insulin resistance and insulin sensitivity. So when somebody's eating tons of meat, dairy, saturated fat, all that stuff, eating a ketogenic low carb diet, they will, if you give them a glucose tolerance test, they do very poorly. And then if they have diabetes and you give them a lot of carbohydrate, like a bowl of fruit or something, their sugar shoots through the roof, because their carbohydrate to insulin ratio would be really bad. So what we call normal physiologic insulin, so how much insulin that your body makes naturally if you don't have insulin resistance or diabetes, is usually about 20 to 40 units per day is about what people would need. So this is more for people with type 1 diabetes. So somebody with type 1 diabetes that has no insulin resistance, they'll only need between 20 and 40 units of insulin per day. But if you know somebody with type 1 diabetes and they're having to inject 80 to 100 or more units of insulin a day, that tells you that they have insulin resistance. And then of course people with type 2 diabetes, they can, even if they're on insulin, they're often on really, really high levels of insulin. There's insulins out there called U500 insulin, which is basically 5 units of insulin for every what normally would be a 1 unit. So there's people out there that are on 300, 400, 500 units of insulin a day just to control their blood sugars, because they have such horrible insulin resistance. And so I just wanted to show you that the keto and low carb, you could have really good blood sugars, but you still have horrible insulin resistance. And you saw from that list how insulin resistance influences all those other health problems. And then not to mention, so anyone that, I see doctors all the time that tell their patients with diabetes, type 1 and type 2, to say, oh, you need to cut your carbs and eat more meat and dairy and all these things. And what they don't really think about is, well, what's the number one cause of death in somebody with type 1 or type 2 diabetes? It's heart disease and stroke. And just like everyone else eating the standard American diet, but it's even worse for someone with type 1 or type 2 diabetes, because when you have, especially with type 2 diabetes, if you have type 2 diabetes, it's called a risk equivalent. What that means is, if you have type 2 diabetes, you have the same risk of having a heart attack or a stroke as somebody that's already had a heart attack or a stroke. So you think about that. It's like someone that's already had a heart attack or a stroke, you're really at high risk for having another one, of course. But that's what the level of risk you have having type 2 diabetes. And so to actually tell a patient with type 2 diabetes to eat more meat and dairy and cut the carbs, what you're doing is adding foods that are going to contribute to heart attack and stroke. And that's what the studies have shown, including the low carb studies that have shown that even though you might have good blood sugars and be at lower risk for your numbers look better, and you'd think, okay, you're going to be at less risk for developing diabetes, or if you have type 2 diabetes, you have better control by cutting your carbohydrates, and now you're eating all this meat and saturated fat and cheese and all these kinds of things, that you're actually going to have a higher risk for heart attack and stroke. And so there was a really good study that was done in Sweden, and they took patients that had already had a heart attack, and they put them on a low carb, or I don't know if it was I think it might have been a prospective study, because I don't know if you get it past an ethics board these days, but they followed people that were on a low carb, more ketogenic low carb diet, and they don't people that were already had a heart attack before, and they followed them for 5 years, and the people that were on the low carb diet, they had a 51% increased risk of death from a heart attack or stroke after 5 years. So it's just not something that's a good idea. So it just really seems crazy to me that any provider would recommend eating a more low carb diet if they have diabetes. So even though your numbers will look better in the short term, and so I can see why you would kind of get mesmerized with that, but you have to really think about what does that mean. And I think this information we have is really tells us why. Okay, so we can go back, we can talk more about that on the questions. I just want to also pay a little attention to some of the other lifestyle factors that influence insulin resistance. So exercise is huge. So whether you do aerobic activity or just walking or resistance exercise, exercising muscle needs less insulin to get the blood sugar inside. So you saw how on that cartoon how you need the insulin to unlock the door so the sugar can come inside the muscle cell. Exercising muscle can actually let sugar come inside much easier and with much less insulin when you've done that, and actually for a full 48 hours after you've exercised. So even 48 hours after you stopped your exercise, your muscles become less insulin resistant and more insulin sensitive. And so that's really great to exercise. And then we all know about sleep and stress, that when you're not sleeping very well, you're feeling more stressed, and you release more cortisol, the stress hormone, because you're not sleeping well and you're stressed about everything in your life. And that actually increases these cortisol levels, and increased cortisol levels actually lead to more insulin resistance and less insulin sensitivity. So does the exact opposite as the exercise. So we really want to pay attention to those things as well. And we all know that when we're stressed and we don't sleep well, we're more likely to not exercise, and we're more likely to make poorer food choices, or more likely to reach for those high sugar, salt, and fat foods and all those processed foods to kind of flood our brain with dopamine and give us our drug fix there. So, and not be choosing a whole food plant-based diet. So I just wanted to pay attention to those aspects of lifestyle that influence insulin resistance as well. So one more quick video about diabetes.
Type 2 diabetes.
And then I think I'm going to skip past to see. Oh, yes. Okay. Just want to make sure I was at the end there. Let's watch Dr. Greger here.
Type 2 diabetes can be prevented, arrested, and even reversed with a plant-based diet. Something we've known since back in the 1930s. Within 5 years, about a quarter of the diabetics were able to get off insulin altogether. But plant-based diets are relatively low-calorie diets. Maybe their diabetes just got better because they lost so much weight. To tease that out, what you need to do is a study where you switch people to a healthy diet, but force them to eat so much food that they don't lose any weight. Then we can see if plant-based diets have specific benefits beyond just all the easy weight loss. Well, we'd have to wait 44 years, but here it is. Subjects were weighed every day. If they started losing weight, they were made to eat more food. In fact, so much more food that some of the participants had problems eating it all. They were like, oh, not another salad. Ugh. But they eventually adapted, so no significant weight change despite restricting meat, eggs, dairy, and junk. So with zero weight loss, did a plant-based diet still help? Overall, insulin requirements were cut about 60%, and half the diabetics were able to get off their insulin altogether, despite no change in weight. How many years did that take? No, 16 days. 16 days later. So we're talking diabetics who've had diabetes as long as 20 years, injecting 20 units of insulin a day, and then as few as 13 days later, they're off all their insulin altogether, thanks to less than 2 weeks on a plant-based diet, even with zero weight loss. Diabetes for 20 years and then off all insulin in less than 2 weeks. Diabetes for 20 years because no one had told her about a plant-based diet. Here's patient number 15, 32 units of insulin on the control diet, and then 18 days later on none. Lower blood sugars on 32 units less insulin. That's the power of plants. And that was without any weight loss. His body just started working that much better. And as a bonus, their cholesterol dropped like a rock to under 150 in 16 days. Just like moderate changes in diet usually only result in moderate reductions in cholesterol, how moderate do you want your diabetes? Everything in moderation may be a truer statement than some people realize. Moderate changes in diet can leave diabetics with moderate blindness, moderate kidney failure, moderate amputation, maybe just a few toes or something. Moderation in all things is not necessarily a good thing. Remember that study that purported to show that diets high in meat, eggs, and dairy could be harmful to health as smoking, suggesting that people who eat lots of animal protein are 4 times as likely to die from cancer or diabetes. But if you look at the actual study, you'll see that's simply not true. Those eating a lot of animal protein didn't have just 4 times the risk of dying from diabetes, they had 73 times the risk of dying from diabetes. Now those that chose moderation, only eating a moderate of animal protein, they just had 23 times the risk of death from diabetes.
You can't solve problems by using the same kind of thinking we used when we corrected them or created them. All right. I talked enough, but you guys ask some more questions.
I have a question.
Yeah,
Go ahead, Beth.
When
And
you
then
were talking
Monica.
about, oh, okay, sorry. When you were talking about 80 or 90 units of insulin a day, did you mean like the short acting and the long acting added together, or what? Like the metabolic, or?
About the patient that reversed their diabetes?
Something you had said about, don't know. It was,
Well, a lot of
you
people.
said 80, 90, 100 units a day, like.
Yeah, so I've had patients on 300 to 400 units a day because they have so much insulin resistance. So normal, if you didn't have any insulin resistance, so let's just say you weren't making any insulin. So whether that's because you had type 1.5 diabetes or type 1 diabetes, you don't make any insulin, and so 20 to 40 units a day is kind of what we consider physiologic insulin. So any of us sitting here in the room right now that doesn't have diabetes and isn't on any insulin injections, we use about 20 to 40 units a day. If we don't have any insulin resistance, we're using 20 to 40 units a day of insulin. And so, of course, it's always, we have insulin that's being secreted all the time, but we get bigger surges of it when we eat food. And so someone that's injecting insulin, they'll be oftentimes using a long-acting insulin and then a short-acting insulin, but there's different kinds. And so when we talk about how much insulin someone uses, we usually talk about the total amount of insulin. So combination of their long-acting and short-acting. It just depends on if some people just inject long-acting and that's it, and then it depends on what their A1C is. But then sometimes if somebody they're on long-acting insulin, but their A1C is still over 8%, 9%, then we start adding some mealtime insulin, short-acting, to kind of cover the spikes that they get with their meals.
Okay, thanks. My dad's on both. Thank you.
You're welcome.
Monica?
Okay, well, I'm kind of confused, but so when you're talking about people taking insulin, is that mainly, always thought that was type 1 diabetes. Type 2 can have to take insulin as well as medication.
Yes, very commonly, because
type 1 can't reverse their diabetes because their body has destroyed the insulin cells, but somebody with type 2 could reverse it by reversing the insulin resistance, and that would also reverse the diabetes.
That's correct. So they have done autopsies on many patients with type 2 diabetes, and the average person that they've done an autopsy on, they found that 50% of their beta cells were destroyed by the time they died. And so that's 50% is still usually enough to not require insulin. You can still limp along with that. But there's many people with type 2 diabetes that have had insulin resistance for so long, and their beta cells are kind of fried, so to speak. And so there's a blood test you can do called the fasting C-peptide test. And I do it on patients all the time when I'm trying to, like sometimes they're not on insulin, they're just on a bunch of, Ozempic and a bunch of these other metformin and all these other medications, and they're changing their diet more whole food plant-based, and they're still having a hard time. They're still sugars are still not coming down that well. And so sometimes I will check this fasting C-peptide on them, and if it's really low, the number, then that tells me that their pancreas isn't really making any insulin anymore, not very much. And so sometimes in those patients, you'll have to give them some insulin injections to get their blood sugars down. And so sometimes, essentially, if their fasting C-peptide is so low, and then you can often even check for these insulin antibodies, and if one of them is positive and their C-peptide is below a certain number, then you could technically say they have type 1.5 diabetes, which I described earlier. So you're essentially become a type 1 a patient with type 1 diabetes in that sense. And so, yeah, at that point, if they're not making any more insulin, you could be on a 100% whole food plant-based diet, do all the things right with lifestyle, and they're still probably going to need a little bit of insulin, even though it's what I want to emphasize is don't feel like if you have to be on insulin, whether you have, well, of course, type 1 always has to be on insulin no matter what, but type 2, even if you're on insulin, in many cases, probably 80% of the cases, you can actually get them off insulin and reverse it. But just because somebody maybe fried all their insulin producing cells and they have type 2 and they always need a little bit of insulin to keep their blood sugars in check, you can still reverse the insulin resistance to a great extent, which then reduces because of all the diet and lifestyle changes, you're still greatly reducing your risk of heart attack and stroke and blindness and amputations and kidney failure and all the things. So I try to really emphasize that it's not just about the insulin.
Okay, great, thanks.
You're welcome.
Someone asked, does Jerusalem artichoke help? So they're a plant food, a plant root, and they've got lots of fiber. And of course, it could help, but it's not going to fix eating a lot of meat, chicken, eggs, and cheese by eating the Jerusalem artichoke. And one single food is something you probably shouldn't rely upon, but a variety of foods, including Jerusalem artichokes, is a healthy choice for sure. Anybody else who has something to question?
Is anybody shocked by the fact that it's really not sugar that causes diabetes, it's fat? Is anyone shocked by that? Of course, we don't want to just eat processed sugary foods because that's just empty calories and excess calories, but it's not the cause of diabetes. People always think that sugar is the cause of diabetes, but it's actually the fat in our diet that causes diabetes.
So
Type
if you
2.
take that one step further, if your doctor or your provider tells you don't eat carbohydrates, what are you going to be eating when you're diabetic? You eat protein and fat. So when your doctor says stop eating carbohydrate and you get that message, you stop eating what? Potatoes and fruit, even though you've heard fruit is healthy for you, fruit and vegetables. So you're confused. You don't really know what to do. Well, hopefully after tonight's discussion, you know what to do. And that's eat whole foods as they're grown in nature. Try to avoid the processing of the foods as much as possible, except for maybe doing a little heating up or whatever.
And you stop eating that doctor's advice.
When it comes to nutrition, that's for sure. I mean, they might be very skilled at everything else, but it's not their fault. They didn't get the training in medical school, just like Charlie and I didn't. So.
Any other questions about this for tonight? Next week, we're going to be kind of going into some different food choices that may be helpful, and it'll be part 2, and you'll have time to ask more questions also, but you still have time tonight.
You have one of my patients gave me a T-shirt that says "I beat diabetes," and they gave that to me. So I've always kept that. I've had many patients that used to have diabetes. So there's actually a diagnosis code for, it's basically status post type 2 diabetes, or history of type 2 diabetes. That's kind of a lot of times medical providers where we have a certain number of patients with certain conditions on our panels. And so when you reverse somebody's type 2 diabetes, that patient with diabetes goes off of your panel. So you almost kind of get penalized for that, because it's like they used to have diabetes. And so how complicated your patients are is how you get reimbursed by the insurance companies. And so you had somebody that was on a bunch of medications and had diabetes, and then you got them on a plant-based diet and healthy lifestyle, and they don't have diabetes anymore, and you took them off all those medications. Now you have a less complicated panel. So the more people you actually get healthy, our medical system essentially penalizes providers for making their patients healthy. If you look at how the payment model is set up, which is really kind of sad, which is one of the reasons I went to community health, because it's not that way there. It's more like other countries' medical system, where you just get, it's capitation. You just get, oh, here's this money. So it's like government run healthcare, where it's just, here's this money to take care of all these people, make them healthy, do the best you can with them, and you already get paid for taking care of them. And instead of getting basically fee for service, where you get more money the sicker your patients are. And so with community health, it's more closer to the model that they use in like Europe and other Scandinavian countries, where it's just everyone has a right to the same healthcare, and it's government run, and here's the money to take care of these people, make them healthy. Whereas it's not that way in our for-profit system here in America.
Trouty, and then maybe one last question, and we're good. Unmute.
I was wondering, how does a doctor get penalized?
Because you penalize in the sense that you make more money the sicker your patients are. So the way that it's the complexity of your patient. So if your patient has heart failure and diabetes and COPD and they've had strokes and heart attacks, and they're on 20 medications, your insurance company will, because that's a very complicated, complex patient, you actually get more money for that patient than you do for somebody that's healthy and isn't on any medication. So the more of those sicker patients you have, the more that the insurance companies pay the clinics, basically, and then the providers, we get a cut of that, basically. And so that's the way the whole U.S. Health system's set up. And they're trying to reward you for trying to manage the really sick patients, and there's plenty of them out there. But then if you were to get everybody healthy, then you wouldn't be getting as much money. So the incentive is backwards. That's just the system we have in America. Unfortunately, whenever it's going to be a for-profit system, it's probably always going to be that way until we can get to go more like they do in Europe and Scandinavian countries, for example, where or like a community health like I'm working at now. Like we get a chunk of money to take care of this bank of patients, and so you just make them healthy. It doesn't matter. I mean, you still get rewarded as far as there are probably some financial incentives for if your patients are healthier, as their blood pressures are coming down, and they're getting their screenings, and their blood sugars are coming down, blood pressure's coming down, things like that. You get those kind of incentives to make them healthier. So that it actually in both systems that does happen a little bit, but overall, getting reimbursed for how sick they are versus how healthy they are. So if you make them in our current system, you make them healthier, you get less.
Thank you.
Matt is
Yeah.
asking why the contradictions with the American Diabetes Association diet. And if you watch the movie video documentary called What the Health on Netflix, you'll come to an understanding of the influence of the food industry, the money that they contribute to the various associations, American Heart Association, American Diabetes Association. You'll understand that money kind of drives the education we receive, and that's not necessarily geared to our health. It's geared toward the profit of the food industries, and that's why the contraindications.
Or the contradictions, yeah. That's why they'll have recipes with eggs and dairy on the American Diabetes Association, and even meat, because they've received funding from contributions from those industries, so they include that. And then there's also the whole kind of what I feel is patronizing attitude of the industry, saying, well, people aren't going to follow a 100% whole food plant-based diet, so what's the next best thing? So let's create a more Mediterranean diet, or a DASH diet, because essentially that's what the Mediterranean diet and the DASH diet are. We know that a completely plant-based diet would be better for high blood pressure when it comes to the DASH diet, and better for heart disease when it comes to the Mediterranean diet. But they try to sell more people on Mediterranean and DASH diet because it does include some meat and dairy products, and so they feel like more people will do it because there are some of those foods included, not because the science supports including those foods. It's just that, well, more people will probably do it if it's more of a moderate diet. But Charlie and I feel like that's a patronizing attitude, because that's not for them to decide, that's for you to decide. You deserve to just know what the science is, and you can make a decision on what you want to eat, not based on what this organization says. Well, you would never do that, so just try to follow this diet.
So Karen asked, do doctors get in trouble for suggesting whole food plant-based diet or vegan diet? So I wouldn't say that doctors necessarily get in trouble. I would say that there aren't a lot of doctors who understand the benefits of a whole food plant-based diet, so they don't tend to promote it. They're kind of surprised if one of their patients is doing that and doing well. I've heard that a lot. And a vegan diet, be careful about that, because you don't really want to be doing a junk food plant-based diet. Many vegan diets have highly processed plant foods, and you don't want that. That's why we encourage you to keep focusing on whole foods as they're grown in nature. All right, Scott, anything else? Last word?
No, hope you guys come back next week and we'll discuss it more talk on diabetes. It's a big topic.
Yeah, thank you all for coming. It was fun. We'll have more fun next week.
All right, thank you.
Welcome. Thank you.
Thank you.
Good night.
Thank you. It was very informative.
Right. Nice work.